Good morning, everyone. My name is Covadonga Fernandez. I'm working the cardiac imaging unit of Ramón y Cajal University Hospital here in Madrid. And it's my pleasure to be here in this virtual Cardio-Oncology summit and this Philips symposium, sharing you some of our cases regarding the use of 3D echo in the evaluation of our patients. This is my disclosure statement slide. And first of all, before we move on to the clinical case that will be in a minute, I would like to remind you the importance of the evaluation of LV ejection fraction in our patients, not just to evaluate the left ventricular systolic function, but to evaluate the ejection fraction and remember and have in mind the important issues that we have to answer every time we face one of these cardio-oncology patients in our everyday clinical practice. So first of all, we need to give quantitative data. There's something that we all know. We need to give a number, and decisions are going to be made regarding that number and regarding different treatment options that we have for our patient. But we also need to be accurate and very important, we need to be reproducible. These patients, we're going to see them very often for many months, even for many years, during and after the treatment. And so we need to be able to be sure that our numbers are accurate and reproducible. And this is because we need to be able to detect changes in serial studies. This is what our guidelines, both European and American guidelines on chamber quantification and LV ejection fraction calculation tell us all the time. We need to quantitate using 2D Simpson rule in case we don't have 3D technology available. But every time that we have the possibility to use 3D echo, we should be using 3D echo. This is what our guideline says, but also more specific guidelines and a statement regarding the evaluation and the management of patients with oncologic treatment tell us that 3D is superior to 2D and that we should be using this technology whenever possible. And why is this? Here, I'm just sharing with you this 3D evaluation of LV volumes and ejection fraction using an automatic quantitation software, 3D dynamic Herm model by Philips. And the reason for using 3D and why we all guidelines and statement works and tell us the same thing is because it's more accurate and reproducible. And this is something that we know for some years already. We have made studies, and there are studies published looking at the reproducibility and accuracy compared to the considered gold standard CMR of 3D echo, and we know it's more accurate and reproducible than 2D. But also now we have the possibility to use automatic software to quantitate, and this software makes things easier for the cardiologists because they're fast, they're easy to use, and in my opinion, we have the possibility to implement this technology in everyday clinical practice. But let's move to our clinical case. It's a 50-year-old woman, female. She has dyslipidemia, and she was a previous smoker, no other cardiovascular risk factor. She was consulted because she had a right breast 5-centimeter nodule in December 2019. Final diagnosis after all the workup was a ductal infiltrating carcinoma, and she underwent a treatment therapy based on neoadjuvancy with liposomal anthracycline cyclophosphamide 4 cycles, each 21 days, followed by Taxol, pertuzumab, and trastuzumab. After that, the patient underwent right mastectomy in July 2020, and then continue the plan, the oncologic treatment consisted of 7 cycles of trastuzumab. If we put all the treatment and all the follow-up of the patient, we have the diagnosis, December 2019, chemotherapy with the plan that I just explained, surgery, and the adjuvant chemotherapy after surgery. So from a cardiological point of view, at the beginning, we made a cardiotoxicity risk evaluation with echocardiography. And as you all know, we have to assess cardiotoxicity risk based on therapy-related factors, but also based on patient-related factors. And in our case, in both aspects, we have a medium risk of cardiotoxicity. We complete the evaluation with a baseline echocardiography. I'm showing you here the 4-chamber, 2-chamber, and 3 chambers view. We get a 2D left ventricular ejection fraction of 61% with normal index and diastolic and end systolic volumes. And if we move to the 3D echo images, we get a 3D left ventricular ejection fraction of 63% with normal index and diastolic and end systolic volumes, as you can see in the images. You can see this is a thin young woman with not exceptional acoustic, but still we were able to make the acquisition and the calculations without any problem. We move on to longitudinal strain. As we can see, we have a normal longitudinal strain, and the patient underwent all the treatment, the chemotherapy treatment, and came back to the lab before a right mastectomy. She didn't have any travel, and all troponin evaluation that was performed as well during the treatment were also negative. In the next echo evaluation, you can see here the 2D images for chamber, 2-chamber, and 3-chamber view. Left ventricular ejection fraction was 58%, with index volumes of 53 end diastolic and 22 end systolic. Ejection fraction were more or less no significant changes compared to the baseline echocardiographic study. We don't see wall motion abnormalities, or we don't see anything remarkable here in this 2D images. But when we move on to the 3D, we can see that left ventricular ejection fraction, 3D left ventricular ejection fraction obtained in this case was 50%. We did a different acquisition, different estimation of 3D ejection fraction, and was around 50% with slight increase in index and diastolic volumes and end systolic volumes. And now when we took a look at the global longitudinal strain, we can see that the global longitudinal strain has decreased compared to the baseline values. I remember you that it was around minus 19, and now we have minus 15. So 2D echo was very similar, and we didn't see anything going on. However, 3D echo and supported by values of global longitudinal strain confirmed that something was going on. So this is a very nice clinical example of the use of 3D echo to detect early myocardial damage over 2D echocardiography, and to illustrate the need to have, whenever possible, precision, so we can make comparison exactly the same way when we do the quantitation in an automatic manner using the same settings in both studies. Just 2 issues regarding 3D echocardiography and how to implement that in our clinical practice. Just make sure that you make a correct acquisition and a correct analysis. Acquisition is important in 3D echo. We need to be aware that we have to have a good ECG signal. We need to have a good 2D image quality. So if we don't have a good image, a 2D image, we're not going to have a good 3D image. And then we have to make sure we have acquired the whole volume. In this case, for dynamic Hertz model calculation, we need to have the 4 chambers inside of the volume. And this is very important, especially if you're starting with 3D, to make sure you have everything inside and no apex or other walls of the left ventricle left outside the volume. And after the acquisition, the analysis is pretty straightforward. You can check the software automatically detects end diastolic and systolic phases, make the chamber segmentation, make the chamber orientation, do the segmentation, but you can check all these parts of the analysis. In case you don't agree or there's something that was not correct, you can edit that, but normally in 95% of the cases you don't have to do this, and normally it's pretty much press the button and get the result. Just to show you the problem with the ECG. When you have a bad ECG, you cannot do anything else. you need to optimize 2D image to get a good 3D images, and make sure you work with not just with the 3D images, with your orthogonal plane, short axis, 2 chambers and 4 chambers view. So make sure everything is inside your volume, so then you won't regret not be able to do the analysis or get wrong results because you don't have everything inside. And for the analysis, just click in the bottom, you will get this kind of images with the end-diastolic phase and systolic phase, with everything, the orientation and the segmentation. And if you agree, you just press accept and you get your results. But then you can do some editing in case you don't agree. You will have the volumes, the ejection fraction, and also the left atrium volumes and ejection fraction, that we haven't talked too much about that, just by a simple click. The data we have regarding this technology is very strong, is very robust, and it makes us confident to use it in clinical practice. We have the data regarding inter-observer and inter-observer reproducibility of the multicenter study, as you can see in this graph over here, both for end-diastolic and systolic ejection fraction and left atrial volume with the herd model and conventional manual evaluation. But also we have that in that multicenter study with different centers that we participated in, but we have done that in our clinical patients also to test the accuracy and reproducibility and the values we get compared to cardiac AMR. As you can see, both this automatic software herd model with CMR and both the automatic 3D, the classical 3D quantitation, the correlation is excellent. And just to conclude, use 3D in echocardiography in your daily practice. It's easy, it's fast, it's more accurate, it's reproducible. It's going to be for the better of your patient. It's going to make you take more confident decision and make the evaluation and the follow-up of your patient easier. Thank you so much for your attention.